Hello, class. Welcome to our first week of lecture. I am Dr. Sarah Lappin. I am coming at you from about 9 in the morning. So I'm gonna spare you how I'm looking this morning. All right. So this week we are going to cover a bit of an introduction into differential diagnosis. So I will go ahead and make this larger so we can go into presentation mode. This week we read a little bit out of the DSM and then a little bit out of the DSM handbook. So a little bit about the DSM, or the Diagnostic and Statistical Manual. It is currently on the 5th edition, but for those of you who may have a little bit of history in the field, you'll know that this isn't the 5th iteration. So for example, the DSM-4 had like the DSM-4, the DSM-4 text revised. I believe it even had one other iteration. But they come out with a new, like, quote, edition or updates to the DSM roughly every 7 to 10 years. So how the DSM is informed, how the diagnostics are informed it's through research. So I'm going to start off this class a little heavy-handed here with maybe an opinion within the field that really, depending upon your theoretical orientation, your lived experience, you may or may not resonate with this. But so the DSM is informed by research. And another thing that is informed by research is evidence-based practices. But one of the things that it's kind of an unfortunate reality of our field is that it's inherently biased. It can be inherently ethnocentric at times, particularly in the United States. It can be very white in terms of its voice because of the research. So everything comes back to researching human beings, researching human behavior, researching humans' responses to different treatments. And what we know is many of the participants in the studies that create the evidence in what we do is largely college freshmen. So we're working with a lot of 18 to 22-year-olds, and many of much of the research that we do is with kind of middle class white individuals. So I just say that because it's always important to be critical of the information that you are learning and really understanding things like, so another thing where research can be inherently biased is who funds it. So, is this study funded by a pharmaceutical company that is looking to get FDA approval? Is there the possibility that the control group and the experimental group might be being treated a little bit differently? So I just say that I do not say that to say, evidence-based practices are garbage, the DSM is garbage, anything like that. I say that for you to always practice a critical eye in terms of understanding who were the participants in this, what was the diversity like in terms of all of the areas of identity with an individual, right? Things like gender, race, sexual orientation, gender identity, ability status, class, nation of origin, language, all of these areas, even things like relationship status, immigration status, religion, the individuals who collect the data may not even collect information like that. So that is the purpose of me saying that, is the DSM is rooted and informed through research. At the same time, our research is culturally bound, and the DSM makes no secret about it being culturally bound. So we'll talk about the DSM and the ICD throughout this presentation and throughout your readings. Okay, so the overarching diagnoses in the DSM, I listed all of these are like areas of like sections of information. So neurodevelopmental disorders, though there's a list. So basically our class is really organized in the way in which the DSM is organized. So we'll have a whole class on neurodevelopmental and where is it? Neurocognitive disorders. We'll have a whole class on schizophrenia spectrum and other psychotic disorders, a whole class on depressive disorders, a whole class on anxiety disorders. So you're going to learn each of these overarching sections or groups of diagnoses a little bit better. So as marriage and family therapists, and quite frankly, depending upon the area or like where you work in terms of if it's in community agency, if it's in private practice, if it's in an inpatient setting, it all depends. But a lot of what we do in our work is other conditions that may be a focus of clinical attention, or V codes. So because we are relationally based, things like, relational distress, these would all be considered V codes. So another thing with the DSM and another thing with mental health in general is we dance not always in step with insurance companies. So really the diagnostic manual and our process of diagnosis is informed heavily by insurance. And sometimes the individuals who accept or reject our billing, I would say the majority of the time, the individuals who accept or reject our billing, they're underwriters for insurance companies who really don't understand anything about diagnosis. So whereas diagnosis is a little bit of a double-edged sword, where there is some stigma sometimes attached to some of the diagnoses and some of the symptomology that we're working with and we are diagnosing. At the same time, it also can open doors in terms of treatments and access to medications and access to money for helping to pay for treatments and stuff like that. So diagnosis is this balance of understanding some of the stigma, holding space for our clients and our patients, again, depending upon the setting that you're working in, of talking about and working through some of this stigma and better understanding some of the stigma, as well as understanding the cultural implications of the diagnoses. So we'll talk about that in later weeks, but really understanding that the DSM and the way in which we even conceptualize mental health disorders, mental health diagnoses is very culturally specific. We'll learn about other cultures who believe in, demons being for example, a reason for some symptomology, whereas we may, in our, again, culturally bound, I guess our culture, where we may be looking at it as like neurotransmitters or, transgenerational trauma and how that maybe affects a individual on a molecular level. We're looking at it as relational, that is, informing some of the anxiety or some of the depression or potentially some of the, sexual dysfunction. So I'm literally just going around and looking at these categories. So these are the overarching diagnoses. This is very close to how our class will be organized. So in terms of navigating the DSM, basically from front to back, the DSM is organized chronologically through the lifespan. So going back to this last one, so neurodevelopmental disorders can be more commonly diagnosed in childhood, whereas neurocognitive disorders are diagnosed later on in in adulthood or young adulthood. So personality disorders, for example, those are generally diagnosed like post puberty, in early adulthood, usually between the ages of 18 and 25. So you can see that is how the DSM is organized. So as you go through it front to back, it's with each of the diagnoses also have age specific information to have a better presentation throughout the lifespan, and understanding, when you're working with a 6-year-old, this diagnosis may present differently than when you're working with a 60-year-old. Genetic and physiological factors, prognostic indicators, and some putative diagnostic markers are highlighted. So you'll see throughout the DSM how these things come out for you to be more discerning in things like differential diagnosis, which we'll be talking about today. Also, just a little note, because this is some language change that has happened in the DSM from the DSM-4 text revised to the DSM-5. So we used to differentiate between substance abuse and substance dependence in our diagnosis. And now these are both considered substance use. So you will have like substance use disorder, SUD, cocaine use disorder, alcohol use disorder, but also all of it, because the differentiation between abuse and dependence talked about things like being physiologically dependent upon a substance, whereas maybe with abuse, you didn't have that type of symptomology. And really what we're finding is it's a little bit more nuanced than that. It's kind of difficult to have this like dichotomy in it, whereas it's either abuse or dependence. And it's, like I said, there's more shades. You have to discern a little bit more closely, and it's more nuanced. So we call them both substance use. Okay, so now moving into the handbook here. So differential diagnosis step by step. So just to be very clear, like what is differential diagnosis? Here I have a little note. It's generally based on the notion that the clinician is choosing a single diagnosis from among a group of competing mutually exclusive diagnoses that best explain a given symptom presentation. So one of the things that you will find as we go through differential diagnosis is you may not have just one diagnosis. And in the handbook, in the vignette or the case study that is presented and demonstrated to you, in that where there may be two best diagnoses. And throughout this semester, we'll be talking about the decision tree very closely with each of the categories that I talked about in the past slide, in one of the past slides. But differential diagnosis ensures that we consider all possibilities before we make a diagnosis for our client or our patients presenting issues. So it involves making a list of all the possible explanation for your client or patient's symptoms and eliminating each one until the correct diagnosis is left or diagnoses are left. So the process of differential diagnosis within the DSM, it's a 6-step process, and I'm going to break down each of these processes as well. So that is how we came to having 12 slides in this PowerPoint presentation. So these go in chronological order. The first step is ruling out malingering or factitious disorder. Once you do that, then you move to step 2, which is ruling out a substance etiology. Then you move to step 3, which is ruling out an etiological medical condition. Step 4, determining the specific primary disorder or disorders. Step 5 is differentiating adjustment disorder from the residual other specified and unspecified conditions. You'll see that many of the diagnoses have other or unspecified, and this language is other specified or unspecified conditions. Other specified and unspecified, that's very specific and purposeful language within the DSM, because what the creators and the contributors of the DSM recognize is that not every no diagnosis is perfect. It's not going to hit, like your client or your patient is not going to present in the exact way that it is written within the DSM. So the DSM allows for some movement with that, through other specified and unspecified conditions where it's a little bit broader, a little bit more inclusive, recognizing that you, like the diagnosis for schizophrenia, for example, may not be exactly how your client is presenting to you. So that, and we'll talk more about that in this presentation of what other specified and unspecified means. And then establishing the boundary with no mental disorder. So those are the 6 sequential steps in this. So the first step, ruling out malingering and factitious disorder. So the process of diagnosis and the process of diagnosing is really this good faith collaboration between you and your patient, or you and your client. So there is the assumption or hope that your client is being truthful with you and explaining symptoms and time and chronology as accurately as they can. Another just note on diagnosis is that some clients, particularly those with some substance use disorder, they can be pretty poor historians. So that makes some of these steps a little bit, they just take time and patience and collaboration with your partner. So if the client is not honest about symptoms, that makes this collaboration much more difficult. But I just wanted to define malingering and factitious disorders to you. So malingering is when the client has a clearly recognizable goal. So their goal is to achieve something like insurance compensation, avoiding legal or military responsibility, obtaining medications, obtaining drugs. So that's what malingering. And factitious is when the disorder or the behavior is present, even when there's not a very obvious external reward, something like insurance compensation. But maybe, their story isn't really making sense to you. Their timeline isn't lining up, the environmental information isn't really making sense to you. So that's where you're wanting to understand a little bit more about the client and if they may be potentially being untruthful. So factitious disorders, this can be kind of what is the word I'm looking for? Like groomed in a child. So you may have heard about some children who, are in wheelchairs with these chronic terminal illnesses. And it's because their parents are like making them sick or making them act sick, or the child has been told their entire life that they are sick when there is nothing medical or organic or physiological about any of the complaints that the parent is sharing. So factitious disorder can be something that's kind of environmentally informed, but malingering and factitious disorder are both defined in the DSM. So this is where you would go to the diagnostic criteria there and look at that. So in step 1, so continuing this with ruling out malingering and factitious disorder, you're going to look for if there is clear external incentive for the client or patient being diagnosed with a certain psychiatric condition. So would they get some kind of disability determination? Would it be helpful in a forensic evaluation in a criminal or civil case? Are they in a prison setting where they may be, I don't know, given accommodations of some sort? So you're also looking for if the patient presents with a cluster of psychiatric symptoms that conforms more with a layperson's understanding of mental health or mental illness, rather than being recognized by a clinical entity. So one example that comes to my mind is like individual. So I don't want to minimize this at all. So with dissociative identity disorder, or what used to be coined multiple personality disorder, where they would go, again, I might be aging myself a little bit here, but like in the 90s when talk shows, like daytime talk shows are really popular, they may have guests on the show who claim to have multiple personality disorder, but they would be able to change their identities like on cue. So they'd be like, so the host may say, like, let me talk to Matilda, let me talk to Sarah. And the person would be able to change it on cue. That has been shown to not be an accurate experience of dissociative identity disorder. So maybe something like that, where they, watch something on TV and notice that. So you're also going to be looking for when the nature of the symptoms shifts very radically from one clinical encounter to another. So if you're seeing a lot of inconsistency with your client or with your patient, that may be an indicator of some dishonesty or deception. When your client or your patient has a presentation that mimics that of a role model, so there may be another patient on the unit or a family member of theirs that has a similar diagnosis, or when you may be looking for when the patient or the client is characteristically manipulative or suggestible. So I did want to note here in this bolded and italicized, a lot of what we do in this field is understanding ourself as a therapist. So you will be doing what's called self with a therapist, understanding how your lived experiences influences your perception as a person and how it influences your professional work. So you really want to understand your nature of being maybe more skeptical or more gullible. So, if you find that, people are able to, influence you emotionally, and that's your tendency, or if you are, kind of more chronically or have a tendency to be less trusting of others, that influences your discernment in diagnosis. So again, one or the other, they're not bad or good. None of these tendencies are inherently bad or good. It's just understanding what your tendency is. So if you are finding, for example, that you are in the when you're looking at case studies or something in this class or other classes throughout your time here at Alliant, that you're like, oh, they're malingering. Oh, this client is not presenting in an honest way. That might be you learning of you being quite skeptical. And that will translate out into your professional world. So just being aware, like if you think that you have a tendency toward skepticism or a tendency toward gullibility, that's an important thing to know about yourself. Okay, so moving to step 2, ruling out substance etiology, including drugs of abuse and medication. So just to define etiology for you, that is causing or contributing to the development of the presenting issue. So the disease, condition, presenting problems. So with ruling out a substance etiology, is you always want to, the first question you ask, so once you've determined this is not malingering, this is not factitious disorder, okay, now we need to rule out substance, because you may find this is malingering, this is factitious, you stop there. That's where step 1, that's where the 6 steps, you wouldn't move through the 6 steps. So if you determine this is not malingering or factitious, the first question you're going to ask is, whether the presenting symptoms arise from a substance that is exerting a direct effect on the central nervous system. And then this step sometimes is overlooked. So missing a substance etiology is the single most common diagnostic error made in clinical practice. I don't know if it's because it's the second step or because we don't think to ask about that, but what we know is that substance use can potentiate or can present as some diagnoses. So we're giving a diagnosis, for example, of schizophrenia, when this may be like a substance-induced hallucination, for example. So make sure that you are asking about substance use and the chronology of that. So within step 2, the first step in understanding if this may be due to a substance is determining if the person uses a substance. So you are taking a thorough history to understand any signs of not only substance intoxication, which can have some symptomology in it, again, things like hallucinations, delusions, paranoia, also understanding substance withdrawal. So you're understanding the points in time when the person sitting in front of you has maybe attempted to abstain from or get off of, stop using substances, and understanding their states and what they can remember when they've been under the influence and they've had some levels of intoxication, and when they've also experienced withdrawal. So withdrawal, you know, you can become ill with this. You can, you know, literally throw up, you can have chills. You know, withdrawing is one of the most dangerous points of substance use, when your body has become dependent in some way on a substance, and then you are no longer giving the body the substance that it has become accustomed to, dependent upon. So understanding what symptoms they've experienced when they've both been intoxicated and withdrawing. So then once system or substance use has been established, the next task is to determine whether there is an etiological relationship between the substance and the psychiatric symptomology. So you will be distinguishing among three possible relationships between the substance use and the psychopathology. So the first is if the psychiatric symptoms result from the direct effects of the substance on the central nervous system. So this can result in a diagnosis of substance-induced disorders in the DSM. So something like cocaine-induced psychotic disorder, or reserpine-induced depressive disorder. So again, the consequences of the substances very well can mimic those of psychiatric diagnostics or some psychopathology. And it is our job to determine, you know, are substances a factor in this? Then the second step is, is the substance use a consequence or an associated feature of having a primary psychiatric disorder? So is it self-medication? Many individuals who have a, you know, the symptoms of a diagnosis, in order to, they may, you know, take it upon themselves to try to mitigate some of those symptoms, or some of the stressors, the consequences, the presentations of those. So looking at some of the temporal relationship, and we'll talk about that in a few slides. And then you want to determine the psychiatric symptoms, and is the substance use independent? So do they just kind of happen to be existing simultaneously? So we're going to go through each of these, the three here, these relationships. So in diagnosing substance-induced disorder, there are three considerations to determine this causal relationship between the substance use and the psychiatric symptomology. So the first is to determine whether there is a close temporal relationship between the substance or the medication use and the psychiatric symptoms. So just to define temporal relationship for you, it is an ordered relationship between a time expression and an event mention. So this is when we use terms like before, after, overlap. So you're just trying to understand the timeline here. So you can ask questions like, did the onset of symptoms precede the substance or medication use? And if they were simultaneous, you may need to a period of abstinence or post-withdrawal phase to accurately define this, or accurately differentiate this, accurately diagnose this. And just a note that this timeline should be flexible. So there's kind of like a 4-week kind of like blanket timeline that some clinicians use, but in certain settings that might not be feasible to take a whole 4 weeks to just assess and to monitor a patient or a client. Also, sometimes 4 weeks isn't enough. So just be aware that there's no like one size fits all observation period for clients. So then once you determine the temporal relationship, you want to consider the likelihood that the particular pattern of substance use or medication use can result in the observed psychiatric symptoms. So you're looking at the nature of the use, the amount of use, the duration of use. So you're looking at all of those to see, you know, oh, when the client uses this amount of cocaine, they experience these symptoms. But when they're not using this amount of cocaine, they don't experience these symptoms. So you're really asking questions with not only the temporal relationship, but also the pattern of use and the consequences of that pattern of use. So then you want to consider whether there's a better alternative explanation. So if it may be a non-medication or non-substance use induced cause for the clinical picture. So this is where you want to include a history of similar episodes that may not be related to any sort of substance or medication use. You also want to look at the family history. So you all may be taking or may have taken classes where you use genograms. So this would be a genogram is a great tool to assess family history of any sort of particular primary disorder, the presence of any physical examination or lab findings. So you always want to have as much information as possible. So sometimes you'll be taking what are called collateral or informant interviews with family members, close friends. If the client has a medical history of doing a release of information to understand what medical professionals with different training may know about or their perception of what is going on. So having as much information about the client as possible. So physical exam, lab findings, where a medical condition may have been involved. So again, staying with step 2 of this, substance taking behavior can be a form of self-medication for the psychiatric condition. So with this, an interesting implication with substance use to self-medicate is that individuals with particular psychiatric disorders often have like a substance class of choice. So for example, with depressive disorders, you may find that your clients or patients they use stimulants with maybe depressive characteristics that are more creating of lethargy, lack of motivation. And then in clients that may have diagnoses with what we consider positive characteristics, things like hallucinations or delusions, that they may use depressants. So they may be using alcohol or maybe using like marijuana or something that like slows down the central nervous system. So just recognizing that. So if you maybe have a hunch that the person may have schizophrenia with positive characteristics, that if you find that they're using alcohol, that may be another clue that your hunch about schizophrenia may be correct. Again, like I mentioned, it may be useful to confer with family members or those close to the person. So these are called informant or collateral interviews. The self-medication or the substance use may be completely independent from the symptomology that they are experiencing, but they very well may exacerbate one another. So for example, when a person is experiencing, more heavy hallucinations, for example, their substance use may increase, or as their substance use increases, it may exacerbate the positive characteristics of something like schizophrenia. All right, so once you have determined substance use, and if that may be an explanation for what is going on, then, so if it is an explanation, then you'll go through a decision tree there and you'll stop. So if you determine, no, this is not due to substance use, now let's rule out a general medical condition. So many individuals with general medical conditions have resulting psychiatric symptoms. So for example, if you have a amputation or something like that, that may be depressing. If you have a chronic illness that interferes with your everyday functioning or your ability to be social, or maybe your ability to participate in hobbies and things that used to bring you lots of joy, and this condition no longer allows you to do that, that may influence some depressive or anxious disorders. So this sentence is twofold. So general medical condition may have resulting psychiatric symptoms as a complication of the general medical condition. And many individuals with psychiatric symptoms have an underlying general medical condition. So the differential diagnosis here, so again, we're differentiating, is this due to a medical condition? Is this due to a psychiatric condition? It can be kind of difficult to differentiate. So here are the 4 reasons to keep in mind as you are going through this decision tree. So symptoms with some psychiatric diagnoses or disorders and some general medical conditions could be identical. So this is where you have good screening, you're asking lots of questions. So while you are in the room with the client or the patient, you are going very thoroughly through presentation and symptoms of the general medical condition and understanding how those may differ from the psychiatric disorders. Then the second reason it may be difficult is sometimes the first presenting symptoms of a general medical condition are psychiatric. So an example here is depression preceding other symptoms in pancreatic cancer or a brain tumor. The third reason is the relationship between the general medical condition and the psychiatric symptoms may be complicated. So some examples here: depression or anxiety as a psychological reaction to having a general medical condition, or the general medical condition being a cause of the depression or the anxiety via its direct physiological effect on the central nervous system. So you can see how those are different. It's kind of like chicken or egg. Was the psychological reaction from the medical condition, or was the medical condition directly affecting the central nervous system, therefore informing some kind of psychological effect? The third reason is that patients are often seen in settings primarily geared for the identification and treatment of mental disorders in which there may be a lower expectation for or familiarity with a diagnosis of medical conditions. So you may not know, like, what are the presenting, like, what is the physiological and psychological effect of pancreatic cancer? You're not going to learn that stuff necessarily in this field or in this program. So this is where consultation is very important. This is where doing your own research is very important while consulting, because we all know the do your own research culture that we're in right now, where if you don't have an eye for it, or if you don't have training in it, your research of it may not be accurate. So when you have a client, for example, come in and say, yes, I have a history of brain tumors, you want to understand, preferably from the people who have treated this individual, what have been some of the consequences of that brain tumor on the client's functioning. How might this affect the central nervous system? How might this present in terms of a psychiatric diagnosis or a psychological diagnosis? So really consulting with others to make sure that your diagnosis is as accurate as possible. So with step 3, so still looking at the general medical condition, virtually any psychiatric presentation can be caused by the direct physiological effects of a general medical condition. So these are diagnosed in the DSM as one of the mental disorders due to another medical condition. So for example, here, depressive disorder due to hypothyroidism. So you should direct the history, physical examination, and lab test toward the diagnosis of those general medical conditions that are most commonly encountered and most likely to account for the presenting psychiatric symptoms. So looking at something like thyroid function tests for depression, brain imaging for late onset psychotic symptoms. So again, you're going to have a familiarity with some of the medical conditions to be able to say, hey, I know that hypothyroidism it can explain some depressive disorders. So really what you're doing is, it's kind of almost like how in like murder cases, I'm going here because I've over the break watched a lot of true crime. It's the ruling out process, right? So you start close to the victim, for example, in murder cases, and your goal is to rule out suspects. So here, if you are suspecting a general medical condition, you are looking closely at the general medical conditions and then working to rule them out. So they are a player in the potential diagnosis until you gather the like thorough enough information to say, no, it can't be explained by this. Let's move on to the next one. So it's the ruling out process of general medical conditions. So you're not trying to like take a psychiatric diagnosis and say it must be this and not looking at medical conditions. You are looking at the general medical conditions very closely. And so you are thinking, I am working under the assumption that it is explained by this general medical condition before it is explained by a psychiatric or psychological effect or diagnosis. So I hope that makes sense. So right now you're like working under the assumption that, okay, it is a general medical condition and I am working to have it not be that. So I'm looking at each of the inclusion and exclusion criteria and all of the presentations of this, so that I can determine that it is not this before I move on to an explanation within the DSM. So again, once a general medical condition is established, the next task is determining its etiological relationship, if any, with a psychiatric symptom. So here are some possible relationships with this. So the general medical condition causes the psychiatric symptoms through a direct physiological effect on the brain. The general medical condition causes the psychiatric symptoms through a psychological mechanism. The medication taken for the general medical condition causes the psychiatric symptoms, in which case, then you would go back to, it would be a diagnosis of a medication-induced mental disorder, and then you would go back to step 2, or you would refer to step 2 to make sure, because you may not. So again, reasons why this is sequential is that when you were talking about substance use, you may, with the client or with the patient, you may have not looked as much at their medication history. So this is another step. It's kind of like a safety net, right? So now we're talking about general medical conditions. Okay, have you been treated for this general medical condition? What medications have you taken? Oh, we didn't look at this very thoroughly in step 2. Let's make sure that we are, we can kind of go back there and double check this. So there's reasons why it's sequentially ordered in this way. So then the fourth relationship is that the psychiatric symptoms cause or adversely affect the general medical condition. So this could be psychological factors affecting other medical conditions that may be indicated. So this is some working more at those toward those V codes. And then the psychiatric symptoms and the general medical condition are coincidental. So they just happen to have hypertension and schizophrenia. They have no relationship to one another. Okay, so there are some clues that can be helpful for you when figuring out, is this a diagnosis or symptoms due to a general medical condition? So the first clue is it involves the nature, again, of the temporal relationship. So before, after, overlapping, what is the time relationship that requires consideration of whether the psychiatric symptoms begin following the onset of the general medical condition. They may vary in severity with the severity of the general medical condition and disappear when the general medical condition resolves. So if the general medical condition is under control or treated in some way, and then the psychiatric symptoms disappear, that can be a clue suggesting that the psychopathology is caused by the direct physiological effect of the general medical condition. Then the second clue is the general medical condition should be considered in the differential diagnosis if the psychiatric presentation is atypical in symptom pattern, age of onset, or course. So, if it's something that a adolescent wouldn't typically be experiencing, or something that wouldn't happen. So for example, you may have like a schizophrenia diagnosis or schizophrenia features in a person who's 60 years old. that's usually diagnosed between the ages of 18 and 25. It's usually presented at that time. So having those features or those symptoms present would be atypical for the first time of somebody who is 60 years old. Okay, so once you have determined that this is not malingering or factitious disorder, this is not due to a substance use, this is not due to substance use, this is not due to a general medical condition, or it is independent of substance use, it is independent of a general medical condition, then you are going to the diagnostic grouping. So then the fourth step is determining the specific primary disorder or disorders. So remembering that the diagnostic groupings are organized around common presenting symptoms. So this is why we have the categories of like depressive disorders. They look similar to one another, but they have specific features that can differentiate between the different depressive disorders. So that the way that the groupings are is meant to facilitate the differential diagnosis. So again, I know I'm talking a lot about schizophrenia, but like schizophrenia, schizoaffective, schizophreniform. So these are all like they're all similar to one another, but they have specific features that differentiate one another. And that's where decision trees will come in. So then step 5 is differentiating adjustment disorders from the residual other specified or unspecified disorders. So adjustment disorder is used a lot in our field as well, where, somebody may be going through a divorce. That is a life event that makes sense for someone to be distressed, or makes sense for somebody's maybe functioning to deteriorate for a period of time. So, or it may be, again, here. So if the clinical judgment is made, the symptoms have developed as a maladaptive response to a psychosocial stressor, the diagnosis would be adjustment disorder. I'm going through a divorce and now I drink a fifth of alcohol every single day. I am going through a divorce and I'm going through a divorce. It was finalized 4 weeks ago and I haven't been to work. That would be considered maladaptive. So if it is judged that the stressor is not responsible for the development of the clinically significant symptoms, then the relevant other specified or unspecified category may be diagnosed, with the choice of the appropriate residual category depending on the DSM diagnostic grouping, which best covers the symptomatic presentation. So again, we'll go to schizophrenia. Schizophrenia has other specified and an unspecified category. So you would go to those and see which, if it other specified or unspecified makes most sense with a diagnosis of schizophrenia. So because stressful situations are a daily feature of most people's lives, the judgment in this step is centered more on whether the stressor is like kind of the catalyst for the presentation, or whether, so it's centered on whether the stressor is etiological rather than on whether a stressor is present. So did the symptomology, the presentation, begin at the same time as the stressor, or has the stressor been there and just now this person is presenting in this way? So those are the questions that you're going to ask yourself. So then the last step in this is establishing the boundary with no mental health disorder. So the common criteria to diagnose any sort of mental health disorder is the disturbance causes clinically significant distress or impairment in social, occupational, or other important areas of functioning. So really with the DSM, we're really looking at functioning. Is this symptomology, is this presentation affecting and negatively impacting the individual's functioning? Because, this person may meet some of the criteria, but they're functioning just fine. So I think of this a lot with sexual disorders and sexual dysfunctions, where maybe somebody, for example, is experiencing erectile dysfunction, but maybe they're not having sex. So that wouldn't be distressing to them, or they're not using their penis for anything. So it's not something that is really noticed or distressing for the client. So something like anorgasmia, the inability to have an orgasm, that might be something that the person isn't distressed about. So you wouldn't give the diagnosis if that person isn't distressed with what is happening. So that also might be something where they don't even really discuss it with you, because it's not something that's creating any sort of tension or distress in their life. So again, it really is centered on the person's experience of that. Is this distressing? Is this interfering in the functioning? So it might be something. So again, going to schizophrenia, hallucinations may not be distressing to the client, but it may be interfering with their ability to function. Maybe they haven't been able to maintain a job, maintain employment. That would still meet criteria. So the DSM makes no attempt to defend or define what is clinically significant. So again, this is on purpose. So the boundary between disorder and normality can be set only by clinical judgment and not by hard and fast rules. So this is where you are having these interviews with the client. You're really understanding your client's experience of their symptoms and seeing how they're affected by it. Another note here, probably to me, one of the most important notes, is that what may seem clinically significant is undoubtedly influenced by cultural context. It's also undoubtedly influenced by the setting in which the individual is seen, your bias, your patient or your client's bias, and the availability of resources. So, a place like Kaiser that has lots of resources may have a bunch of assessments, all of this access to different ways of understanding, other explanations for the client's presentation, and then you may go to, rural California where, you're working at the only hospital within a 50-mile radius, with very little resources, not very much money to fund mental health clinicians. That is going to affect the diagnosis. So just understanding that culture, setting, bias, and availability of resources all affect a diagnosis. And then some quote normal. This is always in quotations because normal is relative, but impairing symptomatic presentations may be worthy of clinical attention, but they don't qualify as a mental health disorder. So they should be categorized as a V code in the DSM or a Z code in the ICD respectively. So this is usually a V code in the DSM, a Z code in the ICD. And that sometimes is affected by if insurance companies will accept that diagnosis and will reimburse for that diagnosis. So then differential diagnosis and comorbidity. So there are 6 different ways in which 2 comorbid conditions, so comorbidity just means like 2 things happening at the same time, can be related to one another. So condition A may cause or predispose condition B. Condition B may cause or predispose condition A. And underlying condition C may cause or predispose both conditions A and B. Conditions A and B may, in fact, be part of a more complex unified syndrome that has been artificially split in the diagnostic system. The relationship between conditions A and B may be artificially or artifactually enhanced by a definitional overlap. And the comorbidity is a result of a chance co-occurrence that may be particularly likely for those conditions that have high base rates. So again, understanding when there are comorbidities, how likely that is. And so the major point in this to keep in mind is having more than one DSM diagnosis does not mean that there is more than one underlying pathophysiological process. So the DSM should be considered descriptive building blocks that are useful for communicating diagnostic information. So differential diagnoses and comorbidity is really when there are 2 possible diagnoses, really understanding the relationship between those two. And if it may be that one is primary, one is secondary, one is happening, and one is actually like able to be diagnosed, and one is like complementary in some way, or just explanatory in some way. But again, so the main point in this is that the DSM diagnoses should be considered descriptive building blocks, useful for communicating diagnostic information. So you're going through and it's descriptive. It is literally taking the inclusion criteria and understanding this is a description. This is a way to describe, again, a culturally bound expression or conceptualization of symptomology. So this is where many clinicians will go through the criteria out loud with the client and have the client explain how they experience that. So again, it's these hard and fast rules can't apply because of how culturally bound and how individually bound some of these experiences can be. And that is it. So please feel free to let me know, communicate with me if you need any further explanation or have any questions, or please make sure to attend both myself and Ivy's office hours if you have any questions about anything.